there is a low production of thyroid gland. As we know that parathyroid gland basically secrete the parathyroid hormone. Parathyroid hormone increases the level of serum calcium and it decreases the level of serum phosphate. But if there will be the growth of parathyroid hormone, it means that the level of the calcium will decrease and the level of calcium will phosphate will increase. So in hypoparathyroidism, we see low serum calcium and high serum phosphate. Due to hypocalcemia, which disease?
Tetany.
Due to low serum calcium, we see a disease which is named as a tetany. Tetany means there is a periauricular numbness or the tingling sensation like here. Periauricular numbness or the tingling sensation. And due to low level of the calcium, we also perform two types of the test. Other two types of the sign we check in patients. One is a Chvostek sign and another one is a Rosé sign. Gurkanan, come here. Usman. For example, this is your patient. And he has a sign, he has a low serum calcium level. How we check the Chvostek sign in this patient? Tab of which nerve?
Facial.
We will tap, this is the patient. We will tap here. When we will tap, if there is a tingling like sensation, it means that this patient has the low level of the calcium. And this type of the sign is known as a which type of the sign? Chvostek sign. And if you want to check the Trozier sign or the Trozier sign, we have to cuff the BP apparatus here, and after that, what happened to the forearm?
Carpal spasm.
This carpal spasm, the spasm will be the occur. And if after the cuff, the spasm occurred into the hand or the forearm, this is known as a Trozier sign. Understand or no? Now, what is the difference between Chvostek sign and Trozier sign? How you will check the Chvostek sign? Get at me. We will add the facial and we focus on the angle of move. If the patient has any kind of movement with tingling sensation like this, then it means that the Chvostek sign is a positive and another sign is a Trozier sign. Just as we check the blood pressure of the patient, we cuff the BP here to the arm and we will see which findings we see into the forearm. If there is a palm noticed into the forearm or in the hand, it means that patient has the positive Trozier sign. And Chvostek sign and Trozier sign both are the findings of the low level of the calcium. Meaning that in low level of the calcium or hypocalcemia, we see Chvostek sign and Trozier sign. Other point, for example, we also discuss a congenital disease, Junaid. For example, a 4-year-old child presents to you with history of recurrent infection, periauricular numbness and tingling sensation, and on echocardiography, you notice the ventricular septal defect. What is your diagnosis?
D. George.
It will be D. George syndrome. When I was starting the lecture, the first thing which I discussed was the George syndrome. In D. George syndrome, we see which type of the things? Low level of the calcium. Due to low level of the calcium, mean the hypocalcemia, there is the sign of the tetany. Periauricular numbness and the tingling sensation. Number 1. Number 2, there is the low level of the T cells. Because third and fourth central pouch not only form the parathyroid gland, this also form the thymus. When thymus is absent, it means that T cells are not going to mature. When T cells will not mature, then we will see the recurrent infection in a patient. Number 2. Number 3, there will be the cardiac anomaly like ventricular defect, atrial septal defect, palpitation of aorta, tetralogy of floor. These are the cardiac anomalies can be seen in these patients who are suffered with the D. George syndrome. And facial anomalies like cleft lip, cleft palate, these are the findings we see. Okay. Another point. This is the hypoparathyroidism. one disease which is known as the Albright dystrophy, Albright hereditary dystrophy. What is mean by the Albright hereditary dystrophy? Albright hereditary
Osteodystrophy.
dystrophy. Guys, in Albright hereditary dystrophy, a child will present to these findings are seen in the child. These findings are we seen to the child. The child will for example, the patient have the one low level calcium. The patient will be the children from over the age of the patient will be, you can say, 6 to 7 years old. One. Number two, there will be the wrong phase. Number three, mental retardation. Mental retardation. Number five, we will see the fourth and fifth metacarpal will be short in size. Fourth and fifth metacarpal will be shorter in the size. Mean that the fourth and fifth metacarpal will be short in size. The size of the fourth and fifth metacarpal will be short. It will be not normal in size. Albright hereditary dystrophy is a condition in which we see number one, low level of the calcium. Low level of the calcium. Number two, what do we see? Rounded face. Round. Number third, mental retardation. Mental retardation. Number five, fourth and fifth metacarpal short in size. If I ever ask an exam that a 6-year-old child presented to you a history of periauricular numbness and the tingling sensation, and your child has a rounded face, and upon examination, the size of the fourth and fifth metacarpal is very short. What is your diagnosis? You guys will say it is a Albright hereditary dystrophy. Albright hereditary dystrophy. Now we discuss
Parathyroidism.
pseudo-hypoparathyroidism. Wherever you read the word pseudo means false. The word is simply allied to us. Okay, in pseudo-hypoparathyroidism, if there is a low level in the calcium in the body, for example, just imagine that Usman has the low level of the calcium in body. What do you think? That the level of the parathyroid is low? Yes. We know that the main function of the parathyroid hormone is to increase the level of the calcium. If the level of the calcium is low, we will think that maybe there is a low level of the parathyroid hormone in the body. That's why the calcium level is low. Understand? Yes. We all know the level of the parathyroid hormone main function to increase the level of calcium. So if we see any patient in which the calcium level is low, we will think that maybe there is a problem with parathyroid hormone, and low level of the parathyroid hormone cause to the low level of the serum calcium. Now notice guys. For example, just imagine here are presence of the parathyroid hormone. We all know parathyroid hormone act on different sites. The parathyroid hormone has its special receptors. The parathyroid hormone has special receptors. Now just imagine, for example, if receptors are not working, can parathyroid hormone work properly?
No.
Parathyroid hormone can't work properly. So the function will disturb. What is the normal function of the parathyroid hormone? Normal function of the parathyroid hormone to increase the level of calcium and decrease the level of phosphate. So that if receptors are not working well, parathyroid hormone will not act on the receptor. Parathyroid hormones are going toward the receptor, but receptors are not working. Just imagine you have a key. Key is a parathyroid hormone, but there is problem in the lock. When you apply the key, do not opening. Why? There is a problem into the law. The same is happening here into the receptor. When receptors are not working, parathyroid hormone coming again and again and again to the site of the receptor, but receptors are not working. It means that parathyroid hormone can't perform its activity. When parathyroid hormone can't perform its activity, then the calcium will increase in the body or no? Then calcium will never increase in the body. It means that the level of the calcium will decrease. But the level of the parathyroid hormone will increase. But the level of the parathyroid hormone will increase. So when we see the labs, in labs there is a low level of the calcium. We think that this person has the hypoparathyroidism. We think but it was a false thinking. In reality, the level of the parathyroid hormone was high. A condition in which the level of the calcium is low, level of the parathyroid hormone is high, and the problem is in the receptors, not into the kidney. The problem is in the receptors. Then this type of the condition is known as a pseudo-hypoparathyroidism. This condition is known as a pseudo-hypoparathyroidism. What is pseudo-hypoparathyroidism? Yes. Pseudo-hypoparathyroidism. तुम मुझसे 20 दफा पूछो, मुझे समझ नहीं आया, मैं 20 दफा बताऊंगा, समझ आया? तुम 25 दफा पूछ, 30 दफा पूछो, तो 30 दफा बताऊंगा। लेकिन अगर तुम खुद मोबाइल में हुए हो और वो मोबाइल से तुम्हें कुछ सुनना चाहिए, पता नहीं, ये जब कोई काम करना होता है उस टाइम हम करते नहीं, जब नहीं करना था वो शुरू कर देंगे। So this was all about the pseudo-hypoparathyroidism. Yes, Haris. कौन से receptor काम नहीं करेंगे?
Calcium sensing receptor.
Parathyroid hormone receptors. कहाँ होते हैं? Mainly these are receptors are present in the kidney. No, maximum these are present in the kidney. Okay, but also present in other sites, other bone. For example, into the stomach, in the stomach. These are receptors are present. But maximum, if someone asks you that what is the location of the receptors, you will give it. It was all about the parathyroid hormone. Now we will discuss about the antidiuretic hormone. मेन डिफरेंस आप जिस जगह बच्चे करते हो ना, इसमें किडनी की प्रॉब्लम नहीं लाई है। ये पेशेंट सीकेडी के साथ नहीं है, समझ आ गया? इस पेशेंट के अंदर वो सीकेडी को फंक्शन करेगा,
एंड ऑर्गन रेजिस्टेंस होगी,
एंड ऑर्गन रेजिस्टेंस होगी, वहाँ पे ये प्रॉब्लम होगा, लेकिन यहाँ पे इस तरह नहीं होता।
सूडो
वो टाइप 1 और टाइप 2 की बैठ गई। टाइप 1 के अंदर पता नहीं होता, टाइप 2 के अंदर प्रॉब्लम होता है। इसमें तरह परेशानी नहीं होती है। एग्जाम के अंदर सिर्फ इस तरह का सीधो हैपर अल्ब्राइट का है। अल्ब्राइट वाला है नीटली डिस्ट्रॉफी के अंदर आप क्या देखते हो? तो आपने ये कहना होता है कि अल्ब्राइट है नीटली डिस्ट्रॉफी के अंदर पैराथायरॉइड हार्मोन का लेवल कम है। जो सब फीचर्स देखते हो उसी के अंदर आप फीचर्स भी देखते हैं, जैसे कि नॉर्मल हो गया, समझ आ गया? आप ये चीजें नहीं देखते। तो दूसरे के अंदर आपने ये
Wait, sponge.
Okay guys, now we will discuss about the antidiuretic hormone. That how antidiuretic hormone released from the body and what is the main mechanism. Antidiuretic hormone, ADH. This hormone is very important. We will also discuss the pathology of antidiuretic hormone with physiology. First we will go toward the physiology. That what is the physiology of antidiuretic hormone? We all know that all the hormones which are secreted from the body receive message from the which part of the brain?
Hypothalamus.
And antidiuretic hormone released from the anterior pituitary or the posterior pituitary?
Posterior pituitary.
Posterior pituitary. Posterior pituitary basically release the antidiuretic hormone and one nuclei which is present
Supraoptic.
in the hypothalamus.
Supraoptic.
In the antidiuretic, which is known as the supraoptic nuclei. We know that supraoptic nuclei which is present in the hypothalamus will give the message to the antidiuretic hormone and then the antidiuretic hormone will secrete into our body. What will happen if antidiuretic hormone is secreted? Antidiuretic hormone is also known as a vasopressive hormone. Also known as a vasopressive hormone. Antidiuretic hormone basically acts on two types of receptors. One receptor is a V1. One receptor is a V2. One receptor which are present on the blood vessels. These are known as the V1 receptors. Just imagine this is a normal blood vessel. This is a normal blood vessel. This is a normal blood vessel. Antidiuretic hormone will come toward this cell. This present on the V1 receptor. When it will give the message to the V1 receptor, then what will happen? It causes a vasospasm. It causes a vasoconstriction. Vasoconstriction. Now tell me. For example, this is a vessel. This is a vessel. When that vessel is narrow, I become easily clear now. No. So the passage of the blood have the more resistant. In this, the total peripheral resistance will increase. When total peripheral resistance is increased, it means that the patient has now hypertension. Hypertension. The total peripheral resistance will increase, and when the total peripheral resistance will increase, it means the patient will go into the hypertension. Number one, guys. Number two, I already discussed about antidiuretic hormone on V2 receptors. I mentioned that antidiuretic hormone give the message to the V2 receptors. With the help of the V2 receptors, it opens the aquaporin channels, and when the aquaporin channels is open, then the water from the fluid from the collecting duct will escape from the collecting duct and it will enter into the blood. And this condition is known as a reabsorption also. And all this mechanism is happening due to antidiuretic hormone. When the blood volume will increase, what will happen? Blood pressure will increase. So the blood volume is going to increase. You guys are handy. What is mechanism of antidiuretic hormone in our kidney?
सर V1 रिसेप्टर्स होंगे वो मैसेज देंगे V2 रिसेप्टर्स को V2 रिसेप्टर्स जो हैं वो एक्वापोरिन चैनल्स को लेंगे और वाटर जो होगा वो
V1 receptor don't give the message to the V2 receptor. Antidiuretic hormone give the message to the V2 receptor. When antidiuretic hormone will give the message to the V2 receptor, then the aquaporin channels will open. When aquaporin channels will open, then the reabsorption of water occurs from the collecting duct to the blood vessel. And in this condition, the blood volume will raise. When blood volume will raise, it means that the blood pressure is going to high. Number one. Number two, if ever asked you in exam that which of following hormone maintain the serum osmolarity?
ADH.
The answer will be ADH. And this question is asked million times in exam. You will say ADH, antidiuretic hormone, is the hormone which basically maintain the serum osmolarity. How it maintains the serum osmolarity? Now we will discuss. Guys, just imagine, for example, anyone of you know about the hyposmolar and hyperosmolar? Umar, what means the hyperosmolar and what means the hyposmolar? What?
Fluid will be dilute and the osmolarity is high in the hyperosmolarity will be associated like low water in electrolytes.
What do you say?
Low water and increased electrolytes.
Shafak, it will be hypo or hyper? Hyperosmolar. Listen, we all know that the solution consists of the two types of things, solute and solvent. Now just imagine, this is beaker, this is the solution. In this solution, there is a soluter present. There is a soluter present. And also the fluid, which is a solvent present. Now just imagine that if a person have a high blood pressure, or if a person do the dehydration condition, when a person have the acute gastroenteritis, meaning that recurrent episode of the vomiting and the recurrent many episodes of, you can say, loose motion or the stool. In this, we are going to excrete a lot of fluid from our body. When the fluid will excrete from our body, then what will happen? Dehydration. You know, dehydration. In dehydration, the fluid is going to excrete our body mainly are the solute. Fluid. We are excreting maximum fluid. So the patient in which condition? Dehydration condition. In a dehydration condition. So when the patient will in dehydration condition, the blood pressure of the patient will be low. Blood pressure will be low. And when the blood pressure of the patient will be low, it means that in the blood, the volume is a high or low? Volume is a low. So any solution, simple, any solution in which volume low, solute high, this type of the solution is known as a hyperosmolar solution. Hyperosmolar solution. Understand or no?
Yes, sir.
Any solution in which volume is low, solutes are high, this type of the solution is known as a hyperosmolar solution. So you guys will say that hyperosmolar solution is a solution in which there will be low level of fluid, low level of solvent, and a high level of the solute. This is known as a hyperosmolar solution. When a person in the dehydration condition and when a person have the low blood pressure,
Yes.
it means that person have the hyperosmolar condition. And we know that when the person has low blood pressure, then the antidiuretic hormone will release. Antidiuretic hormone will release. When antidiuretic hormone will release, what it causes? It causes increased blood pressure with the help of vasopressin, and another mechanism is with the activation of the B2 receptors and the opening of the aquaporin channels, and then the reabsorption occurs from the kidney tubules to the blood vessels.
Yes.
When the reabsorption is happening, I will come to you. When reabsorption is happening, then what will happen? It's when the maximum fluid is going into blood. When maximum fluid is going into blood, then the blood pressure will
Increase.
Blood volume will raise. And any solution in which the blood volume or the fluid is high, solute is low. This type of the solution is known as a hyposmolar solution. Understand or no?
Yes, sir.
And hyposmolar solution. Any solution in which fluid is high and solute are low. This type of solution is known as a hyposmolar solution. Hyposmolar solution. If someone asks me a question that which type of the solution causes the activation of antidiuretic hormone?
Hyperosmolar.
Hyperosmolar solution basically causes the activation of antidiuretic hormone. We know that when a person have the low blood volume, when the person in a dehydration condition, it means that the person have the low it means that the person have the high antidiuretic hormone release condition. And if a person have the high blood volume, if a person in a hypertension condition, this type of the solution is known as a hyposmolar solution. Then antidiuretic hormone will release or inhibit. Understand or no?
Yes, sir.
So this type of the hormone is the main hormone which maintaining the serum osmolarity. How? When the serum osmolarity will be high, it will increase in amount. The secretion will be high. But when the serum osmolarity will be low, then antidiuretic hormone will not release. And this is a physiology of antidiuretic hormone. If anyone of you have a question, you can ask.
Clear, sir.
Yes.
ये पूछना था सर कि क्वालिटी है ना फ्लूइड लॉस बड़ा मतलब इलेक्ट्रोलाइट्स से ज़्यादा नहीं लॉस होता है डिहाइड्रेशन के केस में तो फिर हम उसको सिर्फ पानी के बजाय ओआरएस या एनएस क्यों देते हैं मतलब सिर्फ पानी
सीधा पानी क्यों नहीं देते? देखिए बच्चों, जब आप क्वेश्चन उनका ये है कि फॉर एग्जांपल जब बंदा डिहाइड्रेशन में जाता है, ठीक है, तो आप सिर्फ और सिर्फ वाटर क्यों देते हैं, वाटर क्यों नहीं देते, और मतलब हम नमकोर या ओआरएस क्यों देते हैं? बेसिकली होता इस तरह है कि जब ब्रो मुस्तफा who leave? No problem, continue then. Continue. And say to them, tomorrow bring the...
I said.
अब देखो, जो पर्सन डिहाइड्रेशन में होता है, समझ आ रही है? अब हो सकता है वो वोमिटिंग की वजह से हो या फिर डायरिया की वजह से, उसके अंदर वो इलेक्ट्रोलाइट लॉस करता है कि नहीं करता है? इलेक्ट्रोलाइट लॉस करता है ना, तो हमने वो इलेक्ट्रोलाइट को पूरा नहीं करना, हमने वो इलेक्ट्रोलाइट को भी पूरा करना है। अगर आप सिर्फ और सिर्फ वाटर दोगे, इलेक्ट्रोलाइट्स आप नहीं दोगे, तो आपकी बॉडी के अंदर सोडियम मेनली जिसका लेवल कम हो सकता है, और लो लेवल ऑफ द सोडियम जो होता है वो आपके ब्रेन के ऊपर अटैक करता है। लो लेवल ऑफ द सोडियम क्या करता है? आपके ब्रेन के ऊपर अटैक करता है।
सेरिब्रल एडीमा
सेरिब्रल एडीमा, सेरिब्रल एडीमा, सेंट्रल पोंटाइन सिंड्रोम, we will discuss just after 2 to 3 minutes। समझ आई कि नहीं? क्लियर है? क्यों? क्योंकि हमने इलेक्ट्रोलाइट को क्या करना होता है, एक तरह का मेंटेन करना होता है। अगर आप इलेक्ट्रोलाइट दोगे नहीं, आप वाटर ही दिए जा रहे हो, तो क्या होगा? इलेक्ट्रोलाइट आपकी बॉडी के अंदर कम हो जाएंगे, और इलेक्ट्रोलाइट मेन थिंग्स होती हैं जो कि आपकी सेल में ब्रेन की इंटीग्रिटी को मेंटेन करना। जब आप ये करते जाओगे, फ्लूइड जो होगा और वो आपकी क्या होगा, एक तरह का ब्रेन के अंदर इकट्ठा होता जाएगा। जब फ्लूइड ब्रेन के अंदर इकट्ठा होता जाएगा तो इसकी वजह से फिर प्रॉब्लम होगी। ठीक है, ऐसे देखते हैं कि बात कैसा है। Okay guys, now we will discuss about the pathogenesis of antidiuretic hormone. Antidiuretic hormone pathogenesis. If a person has the hypovolemia, no problem. If a person has the hypovolemia, it means that he has a high serum osmolality. Antidiuretic hormone will release or no? Antidiuretic hormone will release in this condition. So now we will discuss about the pathogenesis of antidiuretic hormone. There are two types. A condition is known as diabetes insipidus, and another condition is known as a syndrome inappropriate antidiuretic hormone. First, we will discuss about the diabetes insipidus. What is the diabetes insipidus? Then we will discuss about the syndrome inappropriate antidiuretic hormone. Okay, first we will discuss syndrome inappropriate antidiuretic hormone. Syndrome inappropriate antidiuretic hormone or the severe inappropriate antidiuretic hormone, which is also known as the SIADH. Which is also known as the SIADH. SIADH, it is a condition in which ADH is excreting more and more and more. Mustafa, what is the function of antidiuretic hormone? Vasopressin one, another
Excretion fluid.
accretion of fluid. Oh brother. What is the function of antidiuretic object? Reabsorption with the help of alcohol channels, with the help of B2 receptors. Now just imagine guys, if a person has enough amount of antidiuretic hormone, when a person antidiuretic hormone is excreting in a high amount, then what will happen? Which means that two things will happen. One is the vasopressin and another one is the maximum of fluid will be reabsorbed from the collecting duct into blood. When maximum of fluid will be reabsorbed from collecting tubules and entered into the blood, what will happen? Blood volume will raise. Blood volume will raise. In this condition, the blood volume will raise. And when the blood volume raise, this condition is known as a
hypervolemia.
And due to hypervolemia, what will happen? Due to hypervolemia, you guys say that the patient will go into the hypertension. The patient will go into the hypertension. This is very, very important, very conceptual topic. Do you remember everything in a good way, inshallah? Small comment. Just I am talking about the antidiuretic hormone. Antidiuretic hormone is a hormone which causes the reabsorption of helium. Mean in the heart will raise or no? Just imagine. We know that this is a room, and we just imagine this is a ventricle. This is a ventricle. And all other rooms are the parts of our body. All other rooms are our part of the body. And if the fluid is high in all other rooms, the fluid will also raise into this room. And this room is a ventricle. This room is a heart. So in hypervolemia, what we see? We see high level of fluid into the heart, into the atria, into the ventricle. The atria and ventricle. Now I have a question from you guys. Which hormone released in hypervolemic condition in which a high level of fluid is accumulated into the atria of the ventricle?
A and B and B.
Very good, shabash. A and B and B and B. You guys will say that A and P and B, these are the two hormones which basically released in response to hypervolemia. In response to hypervolemia. What I said earlier, that hypervolemia, not hypovolemia. A and P and B and P released in response to hypervolemia, not hypovolemia. Listen. For example, we know antidiuretic hormone is a hormone which basically causes the reabsorption of the plaquin to produce the fluid related to the blood vessel. So the hypervolemia. It will cause hypervolemia. The reabsorption is going to happen. The fluid is going into blood vessel. When the fluid is going into blood vessel, it causes hypervolemia. When there is the hypervolemia, then the maximum fluid will enter into the heart. When maximum fluid will enter into the heart, it means that A and P and B and P excrete. It is that A and P and B and P will excrete. What happens when A and P and B and P excrete? No comment. A and P and B and P are two hormones which play an important role for excreting the fluid from our body. These are very important hormones which play an important role in excreting fluid from our body. How they excrete? Just imagine, we know that these are the nephrons. We know these are the nephrons. Just imagine, these are the tubules of the kidney, and the vessel which enter into the glomerulus. This vessel is known as the afferent artery. Afferent artery. A and P and B and P basically dilate the afferent artery.
Yes.
For example, when this is a vessel, this is a vessel. This is a vessel. From this vessel, the fluid comes like this, and the kidney tubules. This is the kidney tubules, and then excrete from our body. So just imagine that A and P and B and P is a hormone which dilates the vessel. When the vessel will be dilated, then maximum will come here or no?
Yes.
Maximum fluid will come. When the maximum fluid comes into the glomerulus, then what will happen? The fluid will come into the kidney maximum.
Increase filtration.
But we know that from the tubules, reabsorption occurs. What happened? Reabsorption occurs. A and P and B and P, both these hormones inhibit the reabsorption of fluid from the kidney. Simple, from nephron. When reabsorption is not going from the tubules, then where the fluid will go? In urine. In urine. You will say A and P and B and P cause the diuresis. A and P and B and P cause the diuresis. What is mean by the diuresis? Loss of fluid in form of urine. Clear?
Yes, sir.
Another point. One is this one. For example, guys, when there will be the hypervolemia, there will be the hypertension.
Yes.
When there will be the hypertension, the maximum fluid is going toward the kidney.
Yes.
When maximum fluid is going toward the kidney, RAS mechanism will active or inhibit?
Inhibit.
RAS mechanism will inhibit. RAS mechanism will inhibit. The secretion of aldosterone will happen or no? Aldosterone secretion will not happen. What is the normal mechanism of aldosterone? Okay. What is the normal mechanism of aldosterone? एल्डोस्टेरोन नॉर्मल मेकैनिज्म ऑफ एल्डोस्टेरोन तो क्या है एल्डोस्टेरोन व्हाट इज द नॉर्मल मेकैनिज्म ऑफ एल्डोस्टेरोन normal mechanism of aldosterone. I discussed yesterday. Carrying sodium from the kidney and we that we can say that aldosterone causes the reabsorption of sodium and excrete the potassium and plasma. Sodium will be reabsorbed, maximum water will be reabsorbed, maximum water will be reabsorbed. And in SiADH, what will happen? In SiADH, what will happen? Aldosterone secretion is increased. When aldosterone secretion is increased, where sodium will go? Sodium will go into urine. Sodium will go into urine. When sodium will go to urine, does the volume will be reabsorbed? No, volume will not be reabsorbed. Volume also goes to the urine. Now, we are seeing two types of the things. Clear है?
Yes, sir.
Listen. अगर कोई पॉइंट क्लियर ना हो तो बता दे, पूछ लेना है, शर्माना नहीं है, ठीक है? इस मामले में परेशान नहीं होना कि हाँ जी अगर सर से पूछेंगे तो क्या होगा पता नहीं, बेइज्जती ना कर दे। मैंने कभी किसी की बेइज्जती की पूछने पे?
नो सर,
ये सवाल है ही नहीं हमारा, ठीक है? अब देखो, आपको पता है कि जब आपकी बॉडी के अंदर ब्लड बढ़ जाता है या हाइपरवोलेमिया हो जाता है तो उसके नतीजे में रास मैकेनिज्म इनहिबिट होगा ना। जब रास मैकेनिज्म इनहिबिट होगा तो एल्डोस्टेरोन रिलीज होगा कि नहीं होगा? एल्डोस्टेरोन कैसे रिलीज होगा? एल्डोस्टेरोन रिलीज नहीं होगा क्योंकि रास मैकेनिज्म अब इनहिबिट है। जब रास मैकेनिज्म ही नहीं है तो एल्डोस्टेरोन नहीं है। जब एल्डोस्टेरोन नहीं है तो एल्डोस्टेरोन का नॉर्मल मैकेनिज्म क्या होता था? रीअब्सॉर्ब ऑफ द सोडियम। अब क्या सोडियम की रीअब्सॉर्प्शन होगी? जब सोडियम की रीअब्सॉर्प्शन नहीं होगी तो सोडियम कहाँ जाएगा? यूरिन के अंदर जाएगा। तो वाटर ऑलवेज फॉलो सोडियम। जब सोडियम यूरिन के अंदर जाएगा तो सोडियम का लेवल आपके ब्लड के अंदर कम हो जाएगा और इस कंडीशन को हम क्या कहते हैं? हाइपोनेट्रीमिया। क्या कहते हैं? हाइपोनेट्रीमिया। Now remember two things in your mind. One, what's happening here? Hyponatremia. Another one is that volumes from coming to the high level to normal level. Not high level to low level. When it will come from high level to low level, first it will come to normal level. First it will come to normal level. If ever asked in your exam, this is very important line. That due to SiADH, which finding you noticed? Euvolemic hyponatremia. What is by euvolemic? Normal volume and low sodium. Normal volume and low sodium. You guys know that how normal volume means that when ANP and BNP were released, ANP and BNP basically excrete the maximum fluid from the kidney used in the form of urine. In the form of urine, it means that the volume from the volume which was the hypervolemia, it will come. First it will normal volume, a condition when it comes to normal volume, it is known as a euvolemic. And on the other side, we also know that aldosterone secretion is not going to happen. When aldosterone secretion is not going to happen, the sodium is going into urine. So the final result is a hyponatremia and a euvolemic. Hyponatremic, a euvolemic. A euvolemic hyponatremia is seen in which condition? SiADH. किसी को क्वेश्चन है?
नो सर।
इतना हाई लेवल का नोटिस नहीं कर रहा हो जाएगा। ANP और BNP होता है। देखिए ANP और BNP जो होता है वो भी सोडियम को रीअब्सॉर्प्शन में होता है। वो भी क्या करता है? एक तरह का सोडियम की रीअब्सॉर्प्शन होता है। क्लियर होगा बच्चों?
यस सर।
Now let's for example. बेटा क्वेश्चन जस्ट इमेजिन क्या होगा? यूरिन की बात कर रही है। यूरिन तो हाइपो में जाती जाएगा तो सारा यूरिन तो यूरिन के अंदर जा रहा है। उसके बाद लेकिन नॉर्मल हम क्या यूरिन कम देखते हैं, ऐसे यूरिन की प्रोडक्शन कम लेकिन तो ज़्यादा वॉल्यूम कहाँ जा रहा है आपका? एक तरह का वो उधर जा रहा है, कंसंट्रेटेड होगा। बाद में क्या होगा? पहले कंसंट्रेटेड होगा, बाद में डाइल्यूटेड होना शुरू होगा। बाद में कभी एक तरह का डाइल्यूटेड होना शुरू हो जाएगा। तो ये आपने देखना है। ओके गाइस, नाउ वी डिस्कस फॉर एग्जांपल वी आर देयर इज अ लो लेवल ऑफ sodium. When there is a low level of the sodium, what will happen next?
Cerebral.
Sodium, low level of sodium causes cerebral edema. When there is a low level of sodium, it can lead to the cerebral edema. And another point, for example, what is the normal value of the sodium?
35.
140, 145. The normal level of the sodium is 140 to 145. Okay?
Yes,
No
sir.
problem. 141 or the 143. Some books write 141, 139. It's not a big deal. 140 to 145 is the normal value of the sodium. So just imagine a patient presents to you and the level of the sodium is 125 or the 122. How you will manage the sodium?
Slowly we will correct. Correct
We will
slowly.
correct slowly. We will correct it slowly. Because just imagine, we have seen the labs of a patient that the level of the sodium is just 120, and we are working as a house officer in any hospital, and in the book we have read that the normal level of the sodium is 140 to 145. We're thinking that the patient is going to die and we have to change the level of the sodium. We should change the level of the sodium. And we'll give the many ampules of the sodium. We give the many high level of the sodium. We are just giving the sodium again and again and again. We are giving, rushly we are giving the sodium level more and more. Then what will happen? It can lead to central pontine syndrome. It can lead to central pontine syndrome. What's mean? If a person have the low level of the sodium, means that the level of the sodium is 120. Okay? You have to change the sodium level very slowly. 120, then you will make something to do the volume of the sodium is a 125. Then you will stop a bit, and then we will go toward the sodium level is a 127. After that, 130, 135 or 133, 140, like this. If you are going to change the level of the sodium very fastly, it will affect the brain. And this condition is known as a central pontine syndrome. This condition is known as a central pontine syndrome. Understand or not?
Yes, sir.
Central pontine syndrome. This can lead to central pontine syndrome. You have it there. This can lead to central pontine syndrome. Now, what is it? What treatment will give the patient of SIADH, guys?
IV hypertonic saline and
Number one,
salt restriction.
we will totally liver the fluid intake.
Yes.
Totally liver the fluid intake. Number one. Number two, what we will do? We will do, as we know that in SIADH, antidiuretic hormone is giving the message more and more to the bleeding receptors, and aquaporin channel is open. When aquaporin channel is going to open, so the absorption of the fluid is occurring. But if we give antidiuretic hormone receptor antagonist drug, then what will happen? Then the fluid will go into the urine and the maximum fluid will not reabsorb. So we can use the anti-hormone receptor antagonist drugs.
Yes, sir.
We can use, yes, in SIADH we use the antidiuretic hormone receptor antagonist drugs. Antidiuretic hormone receptor antagonist drugs. Mustafa, you know that in SI there is a high level of the antidiuretic hormone. When there is a high level of antidiuretic, how we will treat? We will treat by giving not working of the antidiuretic hormone receptor, mean antidiuretic hormone receptor antagonist. When we will give such type of the drug which will block the receptor of the antidiuretic hormone, so antidiuretic hormone will not work. When antidiuretic hormone will not work, so maximum fluid reabsorption is not going to happen. So the volume will be normal. Which are the drugs?
Conivaptan,
Not furosemide is a diuretics. It is a diuretic.
demeclocycline.
These are the drugs, and also one antibiotic, demeclocycline. Demeclocycline, tolvaptan, conivaptan. These are the drugs which basically block the receptor of antidiuretic hormone. Clear?
Yes, sir.
Now we will discuss diabetes insipidus. Diabetes insipidus. diabetes insipidus, it is a condition in which either antidiuretic hormone is not working or antidiuretic hormone is not producing in an enough amount. Understand or no?
Yes, sir.
Two types of the problem. Either the problem is there in the brain, which is known as the central diabetes insipidus,
Insipidus.
When antidiuretic, where antidiuretic hormone excreted, formed, where antidiuretic hormone are produced, in a thalamus, with the help of which nuclei? Supraventricular nuclei.
Supraoptic.
This nuclei where present? Which nuclei? Which nuclei? Supraoptic nuclei. Supraoptic nuclei give the message to the posterior pituitary and produce the antidiuretic hormone, and then the antidiuretic hormone released from the posterior pituitary. Just imagine if a person has a problem into the posterior pituitary, if the pituitary gland is not working properly, the antidiuretic hormone will release or no? The antidiuretic hormone will not release. When antidiuretic hormone is not releasing, the fluid from the kidney tubule will reabsorb or no? What is the normal function of the antidiuretic hormone, Mustafa? Reabsorb fluid, simply. And if a person is not producing antidiuretic hormone in an enough amount, it means that antidiuretic hormone will not go to the receptor of the kidney or the kidney, which are present in the collecting duct, are named as a V2 receptor or aquaporin channels. When antidiuretic hormone are not going to kidney in an enough amount and aquaporin channels are not going to open, so the fluid from the kidney tubule will not escape and will not enter into blood. It will not into blood. And this type of the diabetes insipidus is known as the central diabetes insipidus. This type of the diabetes insipidus is known as the central insipidus because we have a problem in the production of the diabetes, antidiuretic hormone. Why we say that this is a diabetes insipidus? Just remember, what will happen in diabetes insipidus? The maximum fluid will be excreted. When maximum fluid will be excreted from the body, the volume will remain into the blood will less or no? Less. And a condition in which the volume remain in the blood in a less quantity, this type of the solution is known as a hyperosmolar solution. You will say that in diabetes insipidus condition, the serum osmolarity will be
low,
high. But maximum fluid is going toward the kidney, maximum fluid is going into the urine. And when as any solution in which the maximum fluid is present, this type of the solution is known as a hypoosmolar solution.
Yes, sir.
This type of the solution is known as a hypoosmolar solution. ज़रा क्या होता है diabetes insipidus वाला सीन बताओ osmolarity का लिहाज से?
ब्लड वॉल्यूम डिक्रीज होगा तो वो होगा हाइपर ऑस्मोलर सॉल्यूशन, और अगर जो फ्लूइड एक्सक्रीट फ्रॉम यूरिन तो वो होगा हाइपोऑस्मोलर सॉल्यूशन।
ये तो हमें डेफिनेशन का पता, लेकिन एंटीडियूरेटिक हार्मोन के अंदर क्या होता है बच्चे, ये बताओ।
एंटीडियूरेटिक हार्मोन
जब सेंट्रल डायबिटीज इंसिपिडस होता है, इन सेंट्रल डायबिटीज इंसिपिडस में हाइपोथैलेमस जो है वो ऑप्टिक से पोस्टीरियर पिट्यूटरी से एडीएच जो है वो रिलीज करवाते हैं। एडीएच जो है वो प्रॉपर वर्क नहीं करता इसमें, नॉन रिलीज एडीएच वर्क नहीं करता, ये एडीएच रिलीज नहीं होता, एडीएच रिलीज नहीं होता। इन सेंट्रल डायबिटीज इंसिपिडस द रिलीजिंग ऑफ द एंटीडियूरेटिक हार्मोन विल बी वेरी लो। When antidiuretic hormone will release in an enough amount, then what will happen? It means that the aquaporin channel will not open. When aquaporin channel will not open, the fluid will not reabsorb the kidney tubules and will not enter into blood. So it will cause the polyuria. When a person is excreting maximum amount of the fluid in the form of urine, the person also feels the thirst.
Polydipsia.
Is in the form also the polydipsia. This is a central diabetes insipidus. Now we'll come to the nephrogenic diabetes insipidus. Just imagine. If there is problem into the V2 receptors, this problem into the V2 receptors. Antidiuretic hormone is producing. Just imagine I am antidiuretic hormone. Okay, this is the V2 receptors which are present on the kidney. When antidiuretic hormone are producing in enough amount, V2 receptors are not working. When V receptors will not work, then aquaporin channels will open or no? Aquaporin channels will not open. When aquaporin channel will not open, then the maximum fluid will go into. When maximum fluid will go into the urine, then this condition is known as a
Nephrogenic
urine. Then what will happen? It means that when maximum fluid will go into urine, this condition is known as a polyuria. Polyuria, and then there will be also polydipsia. Now, where is the problem? Problem is in the kidney. A condition in which the problem is in the kidney, and the patient has the diabetes insipidus. This type of the diabetes insipidus is known as a nephrogenic diabetes insipidus. Clear?
Sir.
Just imagine, Usman. This is a central diabetes insipidus. This is a nephrogenic diabetes insipidus. In central diabetes insipidus, antidiuretic hormone is not produced in enough amount. In nephrogenic diabetes insipidus, antidiuretic hormone are producing, but V2 receptors are not working properly. Now we are going to test that this patient is either suffering with nephrogenic diabetes insipidus or central diabetes insipidus. And we all know that in diabetes insipidus, the volume in the urine is maximum. The volume in urine is maximum. When the volume in the urine is the maximum, the urinary osmolality will be high or low? Urine osmolality?
Low. Hyposmolar.
Maximum volume is going into the urine. Meaning diabetes insipidus, where volume? Into the urine.
Urine.
So the urinary osmolality is low. But the serum osmolality is
High.
For example, if examiner asks a question like this, that a patient present to you will complain of the polyuria and the polydipsia, and after infusion the antidiuretic hormone, after infusion the desmopressin, there is no change. There is no change with this urinary osmolality or serum osmolality. What is your diagnosis?
Nephrogenic.
It is a nephrogenic diabetes insipidus. For example, in nephrogenic diabetes insipidus, there is a problem into V2 receptors. If I am a desmopressin, okay, and desmopressin is given in patient, there is no problem with the desmopressin, there is no problem with the antidiuretic hormone which is excreted from the brain, there is problem with the kidney. If you want to treat this patient, first you have to treat the kidney problem. Okay? So, if examiner asks you a question like this, that a patient presents to you with a claim of the polyuria, the polydipsia, and upon giving the desmopressin or antidiuretic hormone, there is nothing change is noticed in osmolality for the urine or the serum. What is your diagnosis? Nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. No, you all in central diabetes insipidus. What happened? This is not producing. This is not producing. If I will give from outside into the body of that guy, then what will happen? It will work. It will work. Then the urinary osmolality and the serum osmolality will change. Then the urinary osmolality and the serum osmolality will change. And if examiner asks you a question like this, I present to you with a complaint of the polyuria, the polydipsia, and upon infusion of the antidiuretic hormone, there is change in the serum and urinary osmolality. What is your diagnosis? This is a central diabetes insipidus. This is a central diabetes insipidus. In nephrogenic diabetes insipidus, we also have to notice that why this patient is taking any type of the drug. Which type of the drug? Maybe this patient is taking the colvectone, ponivectone, and macrocycline. If this patient is taking these type of drugs, then what will happen? It means that these receptors is already inhibited by these drugs. We have to just say to that patient, don't take drugs, don't take these type of drugs, you will be fine.
Yes.
You will be fine. And the patient who suffer with the diabetes insipidus, this patient maybe have any type of a trauma, maybe craniopharyngioma,
Brain injury. Yes, sir.
non-functional pituitary adenoma, any hemorrhage, any ischemia. This can lead to the central
Diabetes insipidus.
What you will do into the central diabetes insipidus or the nephrogenic diabetes insipidus? Which test will you perform? Ali,
Water deprivation test.
water deprivation test. Guys, just a minute. If you didn't drink water from the morning, if you didn't drink water from the morning, how many times you will go to the restroom for urination? Just 1 or 2 times. Just 1 or 2. Yes, not more than 1. If a person is not to drink the water, he is going to urinate or no? He should not urinate.
Yes, sir.
But if a person didn't drink the water and he is going to again and again to the restroom for urination, it means that there is a problem into the antidiuretic hormone. So we will perform a test which is known as a water deprivation test. What is the name of the test?
Water deprivation
test. This test is known as a water deprivation test. And in this disease, what we will recommend? There is a problem into the central diabetes insipidus. We will give the Desmo test.
Desmo.
Desmo test is the other name of the antidiuretic hormone. Desmo test is
Analog.
the other name of a antidiuretic hormone. Desmopressin is the other name of antidiuretic hormone. Another thing, what we will say? So just imagine, guys, the fluid which is drank by that guy, all the fluid is going into the urine, and the volume of the blood is low. We will say that patient drink maximum fluid, because this person has the low blood volume. We will say drink maximum fluid. It is not going to give you any type of a problem. But in nephrogenic diabetes insipidus, what we do? We give the medication like indomethacin,
Myloride.
These medication we mostly recommend in a nephrogenic diabetes insipidus. So it was all about antidiuretic hormone
And SI.
syndrome inappropriate or the inappropriate antidiuretic hormone,
Diabetes insipidus.
diabetes insipidus, central diabetes, nephrogenic diabetes insipidus. Before this, we also have read about the parathyroid hormone, hyperparathyroidism, primary hyperparathyroidism, secondary hyperparathyroidism,
Tertiary.
and
Tertiary.
tertiary hyperparathyroidism,
So hypoparathyroidism.
pseudo-hyperparathyroidism, hypoparathyroidism, albright dystrophy. Now we will continue to and we'll discuss about the
Oxytocin.
growth hormone.
Growth hormone. Okay.
Just
Oh.